Hi, everyone. I'm Maureen McMahon. I'm a rheumatologist at UCLA David Geffen School of Medicine, and I'm going to talk to you today about ethnic disparities in lupus. Here are my disclosures. So our learning objectives today are to try to understand the most recent data that we have regarding the prevalence and incidence of lupus in the US, and to explore the impacts of race and ethnicity on disease activity and damage progression in lupus. We'll also discuss factors that may contribute to racial and ethnic disparities in lupus and consider how we can use what we know about these disparities to impact our management of lupus therapies. So we know from recent data that the overall incidence of lupus in the United States is anywhere from 4.6 to 5.6 per 100,000 people. Of course, lupus is much more heavily favored in females, with a ratio of about 9-to-1 females to males. And when you look at patients of Black and Hispanic descent, you can see that those patients often present at an earlier age. The overall incidence and prevalence, as we'll discuss, is much higher in those patients. And in addition, those patients also have more severe disease and more long-term complications. So here we have some of the most updated data that we have regarding the prevalence of lupus in the United States. And this is a meta-analysis of data from 4 different CDC-funded registries, the Georgia, New York, California, and Michigan registries. And you can see overall that when you look at the overall prevalence of lupus in the United States, it's about 128 patients per 100,000 persons. Now, when you look and compare that in Hispanic patients, the incidence is about 120 per 100,000 people. But in Black patients, it's about 230 per 100,000 persons. Now, in a separate registry that was not included in the meta-analysis because the methodology was a little bit different, you can see that the overall prevalence among American Indian and Native Alaskan peoples is about 270 per 100,000 persons in the US. Now, this is data that we included here just to kind of give you a flavor for the overall incidence and prevalence of lupus by country. You can see that the overall incidence is highest in Brazil, followed by the US, and the prevalence is highest in Puerto Rico, again, followed by different US cohorts. Whereas when you get down to Eastern European cohorts, the incidence and prevalence are much lower. So you can also see that the prevalence of different disease manifestations is higher among patients of different racial and ethnic backgrounds. This is data that was compiled by one of our current UCLA fellows when he was working in San Francisco. And you can see overall, when you look at renal manifestations, those are significantly higher in patients of non-Hispanic Black descent, also Hispanic descent, and Asian or Pacific Island descent. In addition, Black patients have higher disease prevalence of musculoskeletal manifestations, neurologic manifestations, and hematologic manifestations. Now, what about survival in lupus? We know certainly that we're doing better at treating our lupus patients and having improved survival when you compare how we were doing in the 1990s, for instance, to how we had been doing back in the 1950s. However, when you look at more recent years, you can see that survival has more or less leveled off and still does not achieve that by the non-lupus population. So certainly we have a way to go, and we need to find better treatments for our patients so that we can improve overall survival. So we'll start with our first polling question. What factors may contribute to increased mortality in lupus? A, Black race. B, early lupus-related damage. C, Asian race. D, end-stage renal disease. E, all of the above. Or F, A, B, and D.
So it looks like the overwhelming answer at this point is E, all of the above, 83%.
A moment to answer. Okay, and as you'll see as we continue talking, the correct answer would be all of the above. So what do we know about mortality specifically among different patients of racial and ethnic backgrounds? Here's some interesting data from the Lumina cohort, which is comprised of patients from the United States and Latin America. And here I think is an interesting example that we really can't lump patients together in big ethnic groups as we may have been doing traditionally. So you can see here that survival is actually highest in patients of Puerto Rican Hispanic descent, whereas survival was lowest in patients of Texan Hispanic descent and of Black racial background. Now, we have other data that demonstrates that mortality is highest in Black patients. This is data from the Georgia Lupus Registry. And here you can see that mortality, both in patients who are followed from the start of their disease or in incident lupus cases and in prevalent lupus cases, that mortality was highest in Black patients compared to Caucasian patients. And I think one of the interesting things from this study is that you can see that those mortality differences start to appear even in the early years of diagnosis. Now, this is data from the California epidemiology study, which also included a higher number of Asian patients. And you can see here that, again, there is increased mortality overall in lupus patients with a threefold increased standard mortality ratio. But when you look at patients, especially female patients who are of Asian descent, those patients had a fourfold increased mortality ratio, and patients of Hispanic and Latina descent had almost a sixfold increased ratio. Now, when you look at the data overall, Black patients with lupus tended to die 6.8 years earlier than Caucasian patients, and Hispanic lupus patients died 9.5 years earlier than Caucasians. Now, again, in addition to what we know about the impacts of race and ethnicity on mortality, we know that patients who are of low socioeconomic status do worse than patients in higher socioeconomic status. And in addition, just certain disease manifestations, and in particular nephritis, can have a big impact on mortality. Here you can see that when you look at any lupus patients that go on to have any type of renal damage, those patients have 14-fold increased risk of premature death. And when you look at patients who have end-stage renal disease, those patients go on to have over a 60-fold increased risk of premature death. Now, we know that even with all of our newer treatments, almost 20% of lupus patients who develop nephritis go on to have end-stage renal disease. So again, this is something that has a big impact on the increased mortality that we see in our patients. Now, what are some other things that may impact mortality? Well, we know that when patients develop damage from their lupus, in addition, not just renal damage, but other types of damage, they are certainly at a higher risk of having mortality overall. And you can see in this study that when patients develop that damage within the first year of diagnosis, 25% of those patients with that early damage died within 10 years, compared to about 7% who did not develop damage early on. So again, the earlier you start to accumulate damage, the worse the overall prognosis is. And you can see, I think, although most of us think we're doing a pretty good job of taking care of our lupus patients, when you really look at the data, you can see that within 1 year, about 10% of patients develop permanent organ damage. But by the time you reach 5 years, that's anywhere from a third to half of patients have permanent organ damage. And as time goes on, those numbers accumulate till you reach almost 100% of patients with some form of permanent damage. So again, I think this also highlights the need to really find more effective treatments for our patients. Now, what about the impact of race and ethnicity on development of damage? Well, here you can see from this study that patients who have, again, lower overall household incomes are certainly more likely to develop damage. But even after you take that and age and other demographic factors into account, you can see that African American patients had significantly higher odds of developing damage. And when you look at patients who accumulated damage in more than 2 areas, African American patients had a 6-fold increase odds for accumulating damage. Now, what other types of things can contribute to risk of damage? Well, we certainly know that the more active the patient is, the more likely they are to accumulate damage over time. But interestingly, if you look at the relationship of disease activity and damage, you can see that although we usually do a better job of getting control of disease activity over the first year in the panel on the left, in those same patients that you can see in the panel on the right, even though disease activity has improved, damage continues to accumulate. So certainly this may reflect some ongoing disease activity that we're not picking up in our activity measures that we currently use. But I think a large contributor to this is also corticosteroids. Now, even as perhaps our daily prednisone doses go down over time, the cumulative prednisone doses, when you look over time, do certainly increase. And that rate of increase often mirrors the rate of increased damage. Now, what are some other types of more specific damage that we look at besides end-stage renal disease? Well, we know from many studies that lupus patients are at increased risk for cardiovascular disease, anywhere from a 7.5-fold to a 10-fold increased risk of myocardial infarction and death from coronary artery disease. And certainly that risk is highest in young patients. We know from Sue Manzi's data that patients who are in the 35 to 44-year-old age group can have up to a 50-fold increased risk compared to their age-matched counterparts. We do have some data looking at the impact of race and ethnicity on cardiovascular disease and lupus. This is data looking at patients from the Medicaid database. And what was found is that patients who are overall of Black descent have a higher risk of cardiovascular disease. When you look a little more specifically at MI, patients who are of Hispanic descent seem to have a little bit lower risk. But when you look at strokes, patients of Black and Hispanic risk both had increased risk. Now, when we think about things such as skin-limited disease, that initially, we may think that those patients have overall not as much risk as patients who have major organ involvement. But I think it's important to remember that African-American patients are much more likely to develop damage when they have skin involvement. And that permanent damage and scarring can have a very significant impact on quality of life. In addition, we know from work done by Megan Klaus, looking at her patients in the Carolinas, that patients who are of Black and Hispanic descent are also at increased risk for pregnancy complications. So that can include obstetric complications, where Black and Hispanic patients had a much higher rate of both multiple different obstetrical complications, and also medical complications during pregnancy. And in particular, when you look at risk of acute renal failure during pregnancy, the odds, even adjusted for different lupus risk factors and socioeconomic factors, Black patients had almost a 3.6-fold increased odds for having acute renal failure during pregnancy, and Hispanic patients had over an 11-fold increased odds compared to Caucasian patients. So this is included in some of your pre-reading material, so we won't go over it in great detail here, but I do think it's a nice review of all the different socioeconomic and environmental exposures that can contribute to health disparities in our patients. So what are some of the additional things that can contribute to the health disparities we see in our patients? I think one of the things that comes up frequently as a thought as to one of the things that might contribute to racial and ethnic disparities is that there could be differences in adherence patterns. And this is some data that supports that to a certain extent. This is data looking at patients in the Medicaid database. And you can see that when you look at adherence to azathioprine, for instance, patients of African-American descent and Hispanic patients were much more likely to be in the non-adherent group of patients. However, that was not consistent when you looked at adherence to mycophenolate. I think the most significant thing to me when I looked at this data was that overall, only 21% of lupus patients in this database had good adherence to lupus medications. So again, I think that adherence to medications is a major issue in all of our patients and something that we need to work on with better strategies and better patient-doctor communication. So certainly there could be some genetic factors that contribute to some of the disparities that we see as well. And I think to go into all of the different genes that could be contributing to this would be a whole talk in and of itself. But I just wanted to highlight one of them just to give us an idea of how genetics may play into the disparities that we see. So there's a gene variant, the APOL1 gene variant, that's seen in a much higher frequency in patients of African descent. There was perhaps some advantage to this gene as patients with the gene variants had protection against trypanosoma infection that's seen in higher frequency in African regions. So we know from data from the general population that this APOL1 gene variant is associated with end-stage renal disease and chronic kidney disease among African American patients in the general population. So this study looked at whether this gene variant could be at play in lupus patients as well. And in fact, the study found that when patients have these gene variants, they're at much higher risk of having end-stage renal disease due to lupus nephritis. And in fact, when patients have the gene variants, they're also more likely to have an accelerated onset to end-stage renal disease compared to patients who don't have the gene variants. Now, interestingly, we have a study from Ashira Blazer at NYU looking at the impact of the APOL1 risk variants on risk for atherosclerosis. And she found that when African American patients had one or more of the risk alleles, those patients had a 7-fold increased odds for having atherosclerotic complications. So not only do genes and gene variants contribute to some of the disparities we see, but there's also some evidence that the environment and genetics can interact through epigenetics to contribute to differences as well. And here's a study that looked at patterns of methylation in patients, in B cells of patients. And you can see here that African American lupus patients had significantly higher hypomethylated regions compared to either African American controls or Caucasian lupus and control patients. And we know that the interferon pathways play an important role in the pathogenesis of lupus. You can see here that when you look at many of the interferon-regulated genes, those areas are hypomethylated and thus interferon regulation upregulated in patients of African-American descent compared to Caucasians and compared to non-lupus patients. Now let's move on to think about how we can take some of what we've talked about and learned about among the different racial and ethnic disparities in lupus and start thinking about how we'll apply that to treatment strategies. One of the things I wanted to discuss overall in the way we're thinking about treating lupus patients is the concept of treating to target in lupus. So we're a little slower to get to treat to target in lupus than we have been in rheumatoid arthritis. But there's a concept that we've been thinking about called the lupus low disease activity state. And this is basically trying to achieve a state in lupus patients where they have low disease activity, no new organ activity, while having prednisone doses that are at least 7.5 milligrams a day or less, and stable doses of maintenance treatments. And it's been shown in multiple studies that when you achieve the low disease activity state, the LLDAS, at least half of the time, that those patients have a slower accumulation of damage over time. Now we have data from Michelle Petrie's group looking at her Hopkins cohort that patients who are of African American descent are slower to achieve the lupus low disease activity state than patients who are Caucasian. So let's go to our second polling question, and I'll start by giving you a patient presentation. So a 24-year-old African-American female presents to your office for a second opinion regarding her diagnosis of lupus. A month ago, she was seen by another rheumatologist and had a positive ANA, double-stranded DNA titers, low complements, malar rash, and arthritis. But she now comes into your office complaining of many of those same symptoms, but also bilateral leg swelling. So you get some lab work and find that on a 24-hour urine test, she has over 6 grams of proteinuria. Her creatinine is 1.3, and she has red cell casts in her urine. You have a renal biopsy done, and it's consistent with class 4 nephritis. So thinking about which treatment regimen to initiate for induction therapy for her nephritis, do you want to start with A, cyclophosphamide, B, mycophenolate, C, rituximab, or D, anifrolumab plus mycophenolate?
So at this point, the winner is mycophenolate at 65% and 21% choosing cyclophosphamide.
Okay, well, I think this could be a discussion all into itself about treatment regimens for nephritis. But as we go along here, you'll see why initially, at least, I would choose B. So this is the most recent treatment recommendations that we have for lupus nephritis. This is the 2012 ACR lupus nephritis guidelines, but it's also very similar to some of the guidelines that have been put out more recently by the European League of Rheumatism and from some of the nephrology societies. And overall, the recommendation is for induction therapy with either cyclophosphamide in the high dose or the urolupus regimen, or mycophenolate. And if a patient is resistant, the recommendation is to switch to the other therapy and or at that point add Rituxan. So that's why I wouldn't choose Rituxan initially for our patient. And then for maintenance therapy, the recommendation is for low-dose prednisone plus either MMF or azathioprine. There's also a recommendation, however, that if a patient is of Black descent, that perhaps you should consider using mycophenolate. And that recommendation is based on some data that we have from the ALMS trial. So in that trial, it was to see if there was equivalence between mycophenolate and cyclophosphamide. And in fact, when we looked at the data broken down into different racial and ethnic categories, we found that patients of Black and Hispanic descent seemed to respond better to mycophenolate than to IV cyclophosphamide. But I think that highlights overall the need to have a diverse population in our clinical trials that's really reflective of the lupus population overall. But unfortunately, as you can see here, Caucasian patients are generally overrepresented in our lupus studies, whereas Black patients are underrepresented in the studies. There's certainly a lot of different factors that go into this, especially the history of racial discrimination that's taken place over time. But I do think it's important for us as a field to work with our patient partners to think about different ways that we can really improve representation in trials. So as you know, we have Benlysta that's been approved. It was the first FDA-approved medication for lupus in 2011 for over 50 years. Now, when you looked at trial data, you can see here the overall trial results were significant in meeting their primary endpoints in both phase 3 pivotal trials. However, when you looked at the phase 2 trials, it appeared that the drug was effective in patients who are Black. But when you looked at the phase 3 trials, there was some question as to whether it was as effective in Black patients, although the trials were not powered to be able to detect any significant differences. And so there was a trial specifically to look at efficacy in African American patients. And you can see from the results here, this is the EMBRACE study results. It's been presented at the national meetings. You can see overall there was a numeric trend toward improvement in Black patients taking Benlysta, 49% versus 42%, although that did not meet statistical significance. And again, when you look at all the secondary endpoints, there was a trend toward improvement numerically, but did not reach statistical significance. Now, fortunately, the safety data was consistent with the larger trials, and there were no safety signals that were seen. So I think this still is not conclusive. It's something that I discuss with patients when making treatment decisions, but this has not prevented me from prescribing in my Black patients. As you all may know, belimumab is also now approved to treat nephritis. So you can see here that in all of its primary and secondary endpoints, it met those endpoints. And so now we have a new add-on treatment to treat nephritis. In addition to belimumab, in the last few months, we have another new treatment approved for lupus nephritis, and that's voclosporin. You can see here the voclosporin met its primary endpoint of renal response at week 52. Now, neither the belimumab nephritis trials or the voclosporin trials were powered to be able to look at patients' response rates by racial or ethnic category. So that's data that we'll have to accumulate based on clinical knowledge after we've used these medications. But I do think it's exciting to have other options as add-on treatments to what we've had in the past, especially thinking about our patients who may be at higher risk for progression to end-stage renal disease. And so I think when we think back to our polling question, as time goes on, we'll need to think about where we're going to incorporate these treatments and whether in patients who might be at higher risk for progression, we may want to be incorporating these treatments right from the start of their nephritis. Now, finally, I'll just mention that there's one other medication that's completed phase 3 trials and is being looked at the FDA right now, and that's anifrolumab. I was able to find some data presented at EULAR by Eric Moran last year, where they did pool the two phase 3 TULIP trials and looked at different treatment responses by different racial and ethnic categories. You can see overall that that anifrolumab met its primary endpoint, but when you look at, again, different racial and ethnic groups, there just were not enough patient numbers to be able to see any significant differences. But it's reassuring that there are trends. So again, this is something to look in the months to come to see whether this gets FDA approval. And finally, I just wanted to close with a little bit of food for thought. I think if you haven't read the article in the New England Journal of Medicine in August of 2020, it's worth a look. It really made me think a little bit differently about how we use racial and ethnic background in our medical decision-making. They pointed out not only that, of course, it can be sometimes absurd to try to fit patients into one category or another, as most patients have very diverse ethnic backgrounds that really could probably fit multiple categories. But they also point out, especially things that might be applicable to our rheumatology practice, when we think about calculating eGFR. When we use those categories, are we using race to, for instance, the racial calculation for GFR in Black patients may lead us to take a longer time or have delays in referring patients for additional care or nephrology visits, for instance. So I think it's worth thinking about these things as we move forward. So finally, in conclusion, the incidence and prevalence of lupus in the United States is higher in patients with Black, Hispanic, American Indian, and Alaskan Native ancestral backgrounds. Lupus manifestations, morbidity, and mortality can be impacted by race and ethnicity. Racial and ethnic disparities in lupus are likely the results of a complex interplay of genetic, environmental, and socioeconomic factors. And developing a better understanding of the potential impact of ancestral background on treatment efficacy can help us to more effectively choose therapies for our lupus patients. Thank you very much.
Thank you, Maureen. That was great.